Good afternoon, everyone. It's 5 p.m., so I think it would be time to start. I think that everybody accepted for recording for the ERN, so we have to welcome you all for this webinar. This is, I think, the 9th or 10th webinar already from the ERN, and the second from the thematic area 3, which is pediatric special electrophysiological conditions. And as a moderator today, I will talk for very little time, and I will let the word from our young people in training to be the main guest for that. So for the reason, we have prepared this webinar with Dr. Miguel Mata from Santa Cruz Hospital. He's a young pediatric cardiologist in the ways of specializing in arrhythmias, and he's in Lisbon, Portugal. And also we have Andrea Greco. He's a young EP also in Sant Joan de Déu Hospital in Barcelona. And they are going to present very interesting cases, and we will have a nice discussion. We would really thank everyone to put on the chat all the possible questions or any things that can be discussed, and we will try to answer them at the end. And they are going to exchange opinions as well. So welcome everyone, and please, Andrea, if you want to start, you are more than welcome. Thank you. Thank you.
Yes, good afternoon, everyone. Thank you, Georgia, for the introduction, and thank you for ERN for the opportunity. The topic we are going to explore today is about arrhythmias and ablations in very small patients, and we are going to use clinical cases to help us. Let's go through the first clinical case. Let's start with the fetal history. We have a 27-year-old woman with no obstetrical history, with a normal morphology scan, but at 35-week scan, our obstetric colleagues see this. In this video, we can see a fetal arrhythmia with significant dilatation of both atria, especially of the right atrium. This is an M mode during the tachycardia that is used in fetal scans to assess the relationship between atrial and ventricular contraction, which in this case was clearly 2-to-1 ratio with an atrial rate of 340 beats per minute and a ventricular ratio of 117 beats per minute. So this is an atrial flutter with 2-to-1 atrioventricular conduction. Following our fetal treatment protocol of our hospital, in case of fetal arrhythmia, we start maternal treatment with sotalol. And during the follow-up, due to the persistence of the atrial flutter, we gradually increase the dose of sotalol up to 80 milligrams every 8 hours. But at 37 weeks, persistence of tachycardia is observed through the majority of the examination. As we can see here, this is sinus rhythm during the examination, and this is the fetal atrial flutter. So the persistent atrial flutter observed throughout the majority of the examination, we decide for an elective cesarean section. So finally, born a male of 3.1 kilos of weight, and at 4 minutes of life, we see tachypnea and progressive increase in heart rate up to 2,220 beats per minute. And this is the electrocardiogram during this tachycardia. We can see the characteristics F waves of the atrial flutter, negative in 2, 3, and AVF leads, with 2-to-1 or 3-to-1 AV conduction. So we moved to the NICU, and we decided to use adenosine for the diagnosis. And this is the electrocardiogram during the infusion of the adenosine, where we can see better the F's waves, characteristics of the atrial flutter, with the AV nodal blocks secondary to the adenosine infusion. And then gradually come back to the previous rhythm. So we confirmed the diagnosis of atrial flutter. Also, we perform an echocardiography during the tachycardia, and we observe a significant dilatation of both atria, especially the right atrium, as we see in the fetal scans, a moderate biventricular dysfunction, a PFO, and PDA. So with this information, we decide to do a synchronized electrical cardioversion at 1 joule per kilo under sedation. And this is the electrocardiogram of the electrical cardioversion, when we can see the transition to a sinus rhythm with a very big P waves. After the cardioversion, no tachycardia episodes were seen during our remote monitoring in NICU and cardiology ward. And this is the remote monitoring, that we can see the normal variability of the heart rate during the day of this child without episode of tachycardia. Regarding the echocardiography at day 3 of life, we see a normalization of the left ventricle ejection fraction and a complete recovery, like here, and a complete recovery of the auricular dilatation.
Which language are they speaking, Anna?
A persistent PFO.
Please make sure you are silent, please.
And here a good biventricular function. So we discharge a patient at 8 days of life without medical treatment, and with a 1-lead ECG monitor, a LifeCore, loaned from our EP unit from the home follow-up. And in this, for the LifeCore, with Miguel, we will talk in more detail about this later. And at a 1-month outpatient visit, we have no episodes of tachycardia on a LifeCore ECG sent by the parents, and we have a normal, completely normal echocardiography with no dilatation of the atria and with a normal function, biventricular function. So in conclusion, we have a male of 1 month old, actually with an adequate growth and without new episodes of tachycardia, with a diagnosis of fatal neonatal atrial flutter treated with synchronized electrical cardioversion. And the plan is a monitoring with the LifeCore cardiomobile in the first months and a regular follow-up with the AP unit. So we can pass to the second case. If you want, Miguel, to share.
Miguel, you are muted. Miguel, you are muted.
Yeah.
I'm very sorry. So as I was saying, I hope everyone can see the slides. And thank you, Andrea, for presenting the first case. And again, thank you, Dr. Brugada, for the kind presentation and for the amazing opportunity of taking part in this ERN GUARD-Heart webinar. So the second case is also of a neonatal atrial flutter, is of a 14-day-old female in terms with 3.2 kilos. In terms of previous history, there was no relevant data in family history, and the antenatal history was unremarkable until the 3rd trimester. She had normal echoes and normal serologies. She had gestational diabetes, but that was controlled with diet. And so she performed the fetal echocardiogram that was also normal. But at 36 weeks gestation, Similarly to the case that Andrea presented, there was a fetal tachycardia of 240 beats per minute. But in this case, the OBGYN specialists unilaterally decided to advance for urgent C-section late in the afternoon. And so the child was born well with an APGAR of 910, almost 3.2 kilos, but was immediately admitted due to the tachycardia to the neonatal ICU. This was during the night. And she initially had an heart rate of 190 with sinus rhythm, but quickly progressed to the SVT that would justify the fetal tachycardia. It was a narrow QRS tachycardia with 260 beats per minute. It was during the night, and despite our tries for neonatology to always perform ECGs during adenosine, there was no ECG performed, so we don't have documentation of the arrhythmia initially. 4 tries of adenosine, IV adenosine were tried, first with 100 micrograms per kilo and afterwards with 200 and 300, always with no effect whatsoever. So they called the pediatric cardiology on call that recommended amiodarone 5 milligrams per kilo IV, and there was actually a pharmacological cardioversion. In the next day, the child was evaluated by the pediatric cardiology department, and the transthoracic echocardiogram had no abnormalities whatsoever, good function, the expected PFO of a child in the second day of life, and the ECG was also quite unremarkable. A sinus rhythm, and other than these premature atrial contractions that were a bit frequent, but no other relevant changes. So, assuming the most frequent etiology for neonatal SVTs, as we all know, it's AV reentry through probably accessory pathways. Treatment was started with propranolol, 1 milligram per kilo, 3 times a day, and the child was discharged well at the 5th day of life. So we get this child at the follow-up after 2 weeks with 3.2 kilos, and already the parents tell us of some notion of unwellness and of tiredness when breastfeeding for 2 days. The parents had been monitoring the heart rate by their own initiative, but with a smartwatch, so we only had heart rate, and the parents said that it was almost fixed at 150 beats per minute in the last 2 days. And they had been adhering well to the medication with propranolol. So the first exam we performed was transthoracic echocardiogram, because the echo was right there and the ECG took like 5 minutes to come. But we immediately saw that there were more atrial than ventricular contractions. There was already biatrial dilation, but mainly in the right atrium. And there was already some mitral insufficiency, some mild mitral insufficiency. And as you all expect, the ECG was quite similar to Andrea's, and we did expect the same course. We saw the classical sawtooth pattern of atrial flutter with the flutter waves positive in the inferior leads, so suggesting a clockwise rotation. And we had a 2-to-1 AV conduction that led to this heart rate of 150 that the parents had already noticed. Since this child was hemodynamically stable, we transferred her to our cardiac pediatric ICU, and we inserted in the first place a synchronous venous line, repeated the exams that were quite similar, and we tried electrical cardioversion. As we know, in most cases, it's quite effective. We tried it with 2 joules and 3 joules. It was a child of 3 kilos, but there was no response. Just remember, everyone, that we always do it with sedation, the cardioversion. In our case, we selected ketamine. And afterwards, we tried it with 2 joules per kilo, with 6 joules. And there were 3 or 4 sinus beats, but then there was a recurrency of the atrial flutter. So we assumed the refractory neonatal atrial flutter to cardioversion. That usually represents 10 to 15% of the cases, and we added flecainide already to the medication that the child was under. So after 2 days, we had achieved our target dosage of 3 milligrams per kilo per day of propranolol and 3 milligrams per kilo per day of flecainide, which was near 50 milligrams per meter square. And we already had some rate control, but not rhythm control. We had the AV conduction had reduced. So we already had 3-to-1 AV conduction with an heart rate that was around 100 beats per minute, but the rhythm was not under control. So we tried electrical cardioversion again. And again, it was refractory. So we decided to progress with medication. We raised dosages of flecainide to 4 and then to 5 milligrams per kilo per day. Of course, always checking and controlling for QTC enlargement and QRS enlargement as well. And after 2 days, we had this beautiful ECG with pharmacological cardioversion and with a clear sinus rhythm, as you can see. And after a while, the echocardiogram already showed very improvements. Sorry, I'm not sure it's okay, playing both. So you can see that there's a normalization of the AV synchrony. There's quite an improvement in terms of atrial dilation and also in terms of mitral insufficiency. And there was also normalization of the left ventricle ejection function. So after 2 days in sinus rhythm, we discharged the baby and we assumed this diagnosis of neonatal atrial flutter refractory to electrical cardioversion requiring antiarrhythmic medication. Eventually, it could have been a late fetal atrial flutter, but we won't be sure. And the child went with medication that we already described of propranolol and flecainide, initially followed up with Holter monitoring. Now, after 3 months, we have maintained rhythm control. The echo continues to be normal. And so we started weaning and we will stop shortly the medication. And we will also use these devices that I actually met on the first time when staying with Dr. George and their team in Barcelona of Alive Cord Cardiomobile. So this is a device that is actually licensed for adults. And so for children to use it, you have to input an adult date of birth, but it's quite useful. And here you can see the video of its usage. Instead of using both fingers to put them in these gray areas, you put the device in the child's thorax. And for 1 minute, it records the ECG. And afterwards, after this full minute has been completed, it emits a PDF. And it's also good in terms of patient data security because the PDF is encrypted. So it's important to remember to share and to define a password in accordance with the parents. I for once use the letter A in small caps. So it's a small password because when they send you the ECGs, they will send it encrypted. So it's quite useful. Let's just finish the last 15 seconds so you can see the result. And it's good also for reassuring parents and for these first days of stopping medication to both the team and the parents being sure of the rhythm control and not only rate control. So you see the tracing, and the tracing is usually quite beautiful. It's one lead, but you have a clear, and this is from one of my patients, you have a clear sinus rhythm. It's also good to tell the parents to try and use the device always in the same direction, because if they reverse it, you can get negative P waves, but as you can see, it's also sinus rhythm. And sometimes you can have some artifacts, and since the algorithm is defined for adults, it can have some misleading diagnosis, and it's our part to reassure the parents, but it's a quite useful device for home monitoring, especially in these small children when you have to adjust medication. So I'll give Andrea back to the third case, and thank you. And in the end, if you have any questions, I'm completely available.
Thank you, Miguel. And we will move forward to Andrea. So he's going to expose another case, another type of approach for neonatal arrhythmias. Go ahead, Andrea.
Thank you, Georgia. Thank you, Miguel, for the interesting case. So let's go through this third clinical case. Let's start with the fetal history. We have a 34-year-old woman with an obstetrical history of 2 first trimester abortion, 1 term cesarean section, and 1 vaginal delivery at 26 weeks gestation with postnatal death for a congenital cystic adenomatoid malformation and an hydrothorax, with a morphology scan normal, but at 27th week scan, our obstetric colleagues during a normal evaluation see this in 2 dimension here, a sinus rhythm, fetal sinus rhythm with a tachycardia. And here in M mode, where we can see the sinus rhythm in M mode, and when we start the tachycardia, this is the M mode of a tachycardia. And these images are characteristics of an SVT with a 1-to-1 AV conduction. In this case, with an heart rate of 240 beats per minute. So at this time, we decide to have a wait-and-see management, especially because it's the first time that we see this tachycardia in the control. The heart rate is not so high, and there are signs of heart failure or hemodynamic failure. So during the follow-up, the first evaluations, we see only sporadic SVT episodes. But at the 29th week scan, we see a very frequent SVT episode with an heart rate up to 2017 or 2018 beats per minute. So here, this is the tachycardia in 2 dimensions. And here on the right, we can see the MO during the tachycardia here and during the sinus rhythm. So following our fetal treatment protocol, in case of fetal arrhythmia, we start maternal treatment with flecainide, 100 milligrams twice a day. And after that, SVT has never been detected during the frequent scan examination in our center. And at the 38 weeks of gestational age, she was admitted to ER due to a premature rupture of membrane, and she had a vaginal delivery. Finally, born a male of 3.2 kilograms of weight, initially admitted to the maternity ward in a monitored room, like always in this type of patient with a fetal arrhythmia. But after 33 hours of life, we see this electrocardiogram. So this is a tachycardia, a narrow QRS with no P waves, normal P waves, and with some retrograde P waves, very difficult to differentiate it. So this is a BST episode without hemodynamic effects at this time. And first, we try the vagal maneuver with ice pack and oropharyngeal gag with spatula unsuccessfully. Then we transfer the baby to neonatal intensive care unit, where we use intravenous adenosis for 3 times at increasing doses. And after the last dose, we have this beautiful ECG that we can comment. After the adenosine, we see that the tachycardia ends with a T wave with some beats in sinus rhythm, and we can see a retrograde P waves in these T waves secondary to the transient selective AV nodal block of the adenosine, characteristics of a concealed accessory pathway, and finally, an extra beat with SVT restart. Then we use a rapid infusion of EV flecainide at 1 milligram per kilo for 2 times, with finally ending of the SVT. And this is the electrocardiogram in sinus rhythm without pre-excitation. So then we start medical treatment with oral flecainide and monitoring in the cardiology ward. At 4 days of life, we see another SVT episode after a blood test with an heart rate of 2,260 beats per minute, finally reverted with 3 doses of intravenous flecainide. And following this, he had multiple episodes of increasingly frequent SVT, necessitated admission to the pediatric intensive care unit and cardiology ward, with a gradually increasing of the medical treatment with flecainide, propranolol, and digoxin, and a slight left ventricle dilatation in the echocardiography. So this is the remote monitoring during the days of admission, where we can see multiple episodes of SVT, some that required medical treatment to stop, and others self-limited. And another things that we can see in this is the gradual reduction of the heart rate of the episodes of SVT as days pass and doses of medication increase. So to resume, we have a patient with recurrent SVT episodes with an hemodynamic repercussion in spite of an optimized medical treatment with flecainide up to 5 milligrams per kilo, a propranolol up to 3.5 milligrams per kilo, and digoxin up to 50 micrograms per kilo. So we decide to do to perform an EP studies and ablation. And these are some video of the EP study. Here we can see the 2 catheters that we use. The little one is the tetrapolar catheter used for sensing and stimulations. And the bigger one is the ablation catheter, in this case, during the electrical mapping of the tricuspid annulus. And here we can see the position of the ablation catheter, this one in the left side of the heart, through the PFO mapping the mitral annulus. This is the tachycardia cycle of 320 milliseconds, approximately an heart rate of 118 beats per minute. And here is a snapshot during the ablation. So in this side, we have the tachycardia with the retrograde P-wave here after the QRS complex. And this is the moment of the ablation when we do the ablation of the accessory pathway with a normal ECG, with a decreased heart rate and a normal intracardiac pathway of the waves. So we perform a PGRT ablation of left posterior concealed accessory pathway. And during the follow-up, after the ablation, we suspend medical treatment. In the remote monitoring of the cardiology ward, we don't have episode of SVT. We see a sinus tachycardia with 119 beats per minute, but with a normal ECG. An echocardiography with a normalized left ventricle ejection fraction with no dilatation of the left ventricle. And we decide to discharge the patient at 24 days of life without medical treatment and with 1 lead ECG, a live core cardiomobile loan from our EP unit. And at the follow-up of 1 month outpatient visit, we have no episode of tachycardia on a live core ECGs sent by the parents, and we have a normal echocardiography. So in conclusion, we have a male of 2 months with an adequate growth and without new SVT episode, with a diagnosis of fetal and neonatal SVT treated with prenatal and postnatal medication, and a PGRT ablation of left posterior concealed accessory pathway. And the plan is and no monitoring with a live core cardiomobile for the first months, and a regular follow-up with the EP unit. So in conclusion, only two things about the limitation and risk of this ablation in this very small patient. First of all, we can talk about the vascular lesions like thrombus, fistulas, and aneurysm. Can certainly be reduced by using ultrasound-guided intravenous access in this type of patient, and try to use the smallest catheter as we can, like 4 or 5 Frenches. Then the valvular lesions, mitral, above all mitral, tricuspid, and aortic valve during mapping, and above all during ablation. In this probably continuous echocardiography during ablation and a prophylaxis with steroids after the ablation can help to reduce these type of lesions. Then the perforation risk in this type of patient, with one of the worst complication, the cardiac tamponade. And usually to avoid this complication, we use less power and temperature during the ablation. Fourth, the saline infusion used for the irrigation of the ablations catheter could cause an overload of fluid during above all long EP studies and ablations, with a consecutive cerebral edema. So we have to reduce the infusion flow during these procedures. And finally, complete AV block is a rare complication, yes, but very important complication, because usually the accessory pathways in these patients are far from the conduction system, but the structure are very close to each other. So it's very important in this patient, the experience of the center. So thank you very much.
That's great, Andrea. Thank you, Miguel. Thank you, Andrea. And I think that you could expose in these 30 minutes the main 3 approaches for those very small patients that we have to deal since prenatal period, and how easy it can be to control a flutter just with a cardioversion, electric cardioversion, and how easy it is to just have that and no apparent recurrences. How complicated it can be, the same flutter, and how much headache you can have, and sometimes medication is needed, and we don't really know the exact amount of cases that they just never recur, or they will give us a lot of problems. And finally, those arrhythmias that are easily controlled during pregnancy, very easily controlled, and then suddenly something happens outside, and all the hemodynamics of the heart changes, and then all those things that were easy to control, they really make a change, and that they become a nightmare. That's I think that's very nice and illustrative cases you both prepared, and I really appreciate. So what maybe, I don't know, maybe Miguel, what would be maybe the explanation for those, why it's so different, your life in prenatal world compared to the postnatal situation?
Thank you, Dr. Jorge, for the comments and nice comments. So regarding this question, we have 2 explanations at the same time. For once, you have the different pharmacodynamics and pharmacokinetics on the prenatal course with transplacental passage of drugs that are used in a much higher dose in the mom than would be in the neonate. Also, the characteristics of each of the drugs that is used in terms of the passage. There's a really nice picture in the paper that was published recently by the American Heart Association regarding these fetal and neonatal tachycardias, and it clearly specifies these changes regarding especially pharmacodynamics, but also the differences in terms of hemodynamics, in terms of the circulation. We go from a fetal circulation where the blood that receives directly the drugs in the placenta goes straight to through the PFO and arrives firstly to the heart, to a different hemodynamic after closure of PFO of the PDA, and also due to changes in the median pressures. The median pressure in the left heart is raised after birth, and these hemodynamic changes, as well as the difference in terms of pharmacodynamics, even with the same medicines, can explain some of these changes. And if there's no control in the fetal tachycardia, as was our case, if this is a fetal tachycardia or neonatal tachycardia with long duration, or if there are other associated arrhythmias, for example, the premature atrial contractions, most series describe these as factors for refractoriness to the first measures and a probable need for antiarrhythmics.
I think that this topic of the fetal treatment in these cases on the fetal tachycardias is very interesting, because it's a field very good with no more studies on this pharmacokinetic, pharmacodynamic of the treatments. So I think it's a very good and interesting topic.
And it's maybe just taking that part, Andrea. It's funny that when we have a prenatal flutter, we give sotalol, and then suddenly when the baby is born, we give flecainide and propranolol. It looks like weird that we are doing such changes, and probably sotalol is a drug that can go with a lot of QT prolongation, and the beta blockade effect on the pregnant women. It's also might be important. Some of them complain that they get really tired. So it's quite a thing, and I know these are the guidelines, and I know these are the protocols, and we here in San Juan de Dios, and many of your centers might be part of this multicentric randomized study of
fetal treatment
for flutter. But it's true that when seeing that, it's kind of funny that we go from sotalol to fleca and propranolol. What's your thought? What are your thoughts concerning that?
I don't know, probably this one, the pharmacokinetic, is different. The pharmacodynamic, the pass through the placenta is different. And I don't know. I don't really know. We saw these cases, our cases, and the case of Miguel, very different, without a treatment in the fetal situation and with a treatment in a fetal situation. We have another child now with a flutter, no responder to the treatment, fetal treatment. So I don't know. I think that is a real good topic to study.
And Miguel, I was concerning that there is a point that now when we work with neonatologists about the dosage for adenosine, that we try to have all these kind of red flags of how we need to do adenosine and how important it is to get those registries, nice tracings before, during, and after, and the dosage for that. Normally starting not at 100 but 200, which would be the advices that you would share with the neonatologist about how we should cope with those arrhythmias.
So as I said, and it's quite exemplified by our case and by Andrea's case, the need for an ECG during adenosine. We have tried with webinars and sessions with neonatology as well, with the ones that work with us, but also in other centers, to imprint them the need for the ECG. Even, well, we tell them that if it's during the night and then don't have the ECG, if they can film the monitorization, it's more than having nothing. But the ECG for diagnosis is essential. And this question that you said, Dr. Brugada, thank you, about the dosage is also important, because we have tried to tell them to not be that afraid of adenosine, which is sometimes different with neonatologists regarding the heart, and to use probably the 200 micrograms for the first dosage, because repeating dosages will increase the catecholaminergic response of the child, and it can decrease the response to the therapeutics. But I think as I said, the labor was during the night, and sometimes the person who is on call is not that into the guidelines, but we've tried to tell them that the cases that they discussed with us, if this child had an ECG during adenosine and we had seen the flutter, probably he wouldn't have started with propranolol, and the approach might have been different. But well, as we see, most flutters also change with electrical cardioversion, so we would have to see. But it's always a great add-on in terms of quality of care, and also in selection of the adequate therapy for each patient, to have it all studied as possible.
Thank you, Miguel. There was a question from the chat, and I welcome everyone to put your questions on the chat, please. Asking about the use of Koala device instead of a LifeCore, Koala device for monitoring of small children. I don't know, Miguel, what are you using in Lisbon? If you have heard about Koala device as well.
We're using mostly Cardia, and as I said, because we didn't have that many home monitoring devices. After I did some training with Dr. Georgia and her team, and after seeing Cardia, I was completely thrilled and brought it here. And so our unit has also acquired some that we give parents for a limited time after they need to start or change medication, or when there's uncertainty regarding the symptoms and you can't get even not with neonatal cases, but if you have a child that has like once every 2 weeks palpitations, even with a 7-day alter, you might not get it. So these devices can stop the need for subcutaneous alters and be a less invasive way. But with Koala, we haven't had that experience. I'm not sure if you in San João de Deu or other centers have used them, and what's your opinion about this?
And Andrea, maybe can you share if you have any experience with other devices in Italy as well?
In Italy, no. I see I know this Koala device. What is, because when I start to use this the LifeCore, I saw all others devices, but I don't know. No, in Bologna usually they use for the adult a LifeCore with the 6 leads, but another devices I don't know.
Okay, so we have 1 minute left for this 45 minutes. So Andrew, he says that he uses Koala in Stockholm, Uppsala, and they have a very good experience with that. So probably we can also have a look at that. We all know that all these devices, most of them don't have pediatric approval, but we use it anyhow, as always. So anyway, so the last minute to just thank everyone, for your presence here to share, and also for our 2 young presenters that I think that we have to promote young presenters to be part of these calls, and also to share their knowledge, their experience. They've been in many places doing rotations in many places in Europe, and I think that we can learn a lot from them, all they have seen. And I welcome, of course, to join to next webinars, and of course to also join the AIPC webinars that are in place as well. So thank you very much, and I hope to see you in the next webinar from the ERN. Thank you.
Thank you, Georgia.